So I thought what exactly we need to know for both of us to understand each other. The commonest problem that we face in the critical care setting is that we call cardiology, we come and say, we'd like to do an echo for this patient. And the cardiologist says, oh, we've done an echo yesterday, you don't need an echo today. Okay, and the echo shows ejection fraction is about 40%. The patient has got some myocarditis. The troponin leak is due to myocarditis. And there's no evidence to suggest that this patient needs an angio. The usual statement that we get from cardiology. And then we get the usual answer, start this patient on aspirin. And by the way, where do they get all these names? Clopidogrel, Besigrel. How do they actually get these names? Because I find them very difficult to pronounce, these ones. Start aspirin, start Plavix, and call if there's any deterioration for the patient, the usual stuff. Then I said to myself, okay, if that's the usual scenario with every case that we refer to the cardiology, what is the reason for them not understanding what we want, and for us not to understand what exactly they mean by what they say? So I prepared this lecture based on this, for you to understand what we do in critical care, so you know how it impacts on the heart and how we think, and at the same time, for me to understand you, so we can speak the same language when we start to refer patients to you. So this is the usual scenario that we usually ask the cardiologist to come, especially in Adan Hospital, when you have patients on ECMO, and we'd like to do daily echo for those patients. And the cardiologists are usually saying, why do you need daily echo for those patients? You have them on ECMO, they're stable. You have other parameters you can look at. And the other one is that the last one, which is somebody who's got an obstructive shock, like a PE, and we call the cardiologist and say, come on, we need an echo on this patient. And they say, why do you need an echo? He's got a PE. Why do you need an echo? He already has a PE, okay? So that's because we have two different languages. We speak something, let's say we speak Persian, and you guys speak English. That's why we don't understand each other. And I said to myself, okay, we have to do something about this. For me to teach you, or for me to make you understand what I want, you have to understand the physiology of what we do in critical care. Now, the difference between CCU in the past and CCU now is that in the 80s, this is the patient in the CCU with a magazine, with antiplatelets therapy, and they might go for an angio, they might not go for an angio. There isn't that much in terms of circulatory support for those patients. But nowadays, we see that there is more and more supportive therapy to patients in the CCU. But those patients, instead of staying in the CCU in this country, where do they go? They go to the ICU, where they have ECMO, they have Impella, they have ECPella, they have LVADs, and all those things. So let's go again. Why do we actually need the cardiologist to know about our practice? Because the critical care science is based on physiology. And I guess this is a common thing between us and you guys. You are a physiology-based practice with evidence to support the physiology that you believe in. We are exactly the same way. Now, we also have a very objective approach to diagnosis. Not only diagnosis, but we have an objective approach to therapy. In other words, you start your angio, you dilate the vessel, and then your objective approach is to see the flow going through the vessel nicely, and then after that you see what happens to the patients over the next few days in terms of recovery of myocardium. We have the same way. We use monitoring to look at those things, and these monitors usually include visually aided monitors. And not only that, patients do fluctuate in the ICU. So what are the physiological principles that we rely on? So we rely on cardiopulmonary interactions, and all of you know that. What is cardiopulmonary interactions? What happens in the lung affects the heart, and what happens in the heart affects the lung. So the left side affects the lung, and the lung affects the right side. As long as you understand that this is a very fundamental element that critical care management is based on, you will not be understanding why we need some sort of visualization of the performance of the myocardium, okay? Now, what else do we do to the heart? We apply PEEP to our patients. We put them on artificial ventilation. And PEEP, what it does, it increases the afterload on the right side of the heart. It doesn't help the right side of the heart. And if we don't augment the right side of the heart by increasing the mean systemic pressure, we're going to end up with a lower cardiac output. So in somebody who is in cardiogenic shock, we put them on a ventilator, we apply PEEP. We might be worsening them if we don't do the right management for those patients. okay? Now, this is again an illustration of PEEP. What is this thing? Anyway, so PEEP, as we said, you can see that if we don't augment the mean systemic pressure, you're going to end up having a lower cardiac output like in point B. As far compared to if you augment the mean systemic pressure, which is basically by using a vasopressor or adding volume, you're going to have point C, where the cardiac output is much better than before, okay? Now, this is an echo picture. You can see, if I call a cardiologist and don't tell him anything about this heart, they will tell me immediately the right side is dilated compared to the left side, there is septal flattening, there is D-shaped ventricle. This is a PE. This is actually of a heart of somebody who is on PEEP. So you need to understand, why do we need to call the cardiologist to come and evaluate the heart in a dynamic way, almost like on a regular way? Now, what else happens? Many parameters do change. Your pulmonary venous return gets affected by the ventilator and the volume that we give to those patients. Your RV afterload gets affected by the ventilator and the position. Sometimes we prone the patients, we put them head down to improve VQ matching for those patients, and that affects the right side in a positive way, or it could affect it in a negative way if the compliance of the heart is reduced, compliance of the lung is reduced. We also affect the preload to the right side, we affect the venous return, and the left side also gets affected in a variable way. So there's a lot of interactions that happens between the left side and the right side. So the second principle is intraventricular dependence, which what happens to the right side can affect the left side. Applying PEEP increases the size of the right side, increases the pressure, impinges on the left side, causes more and more diastolic dysfunction, and probably puts this patient in heart failure. So that's the second principle that we look at. The third principle is, once we get the blood going into the left side of the heart, then it comes the arterial system and the compliance of the arterial system to generate the right blood pressure. And that's what's called ventricular arterial coupling. And that's the third principle that we look at. And if you look at all these things and you combine this with contractility issues that we see in sepsis or in most of our patients, you're going to get a patient who is really shocked. Now, after all this, we are like this. Okay. This video is about John Biden walking around saying, I don't know where I am. And this is how we are in the ICU with all this, with the ventricular coupling, with the ventricular dependence, with the cardiopulmonary interactions, with the ventricular arterial coupling. And it's basically showing you how we feel when we see a patient who is shocked. So what's the solution for this? So the solution is to do a dynamic echo for those patients. Why? Because we need to look into that darkness. That's why we call, Dr. Hamidan says, we need an echo for this patient almost like on a regular basis to evaluate the function of the heart. What's the proof that a dynamic daily echo is going to help the intensivist in managing the disease? Now, we have a consensus that came out from a task force, the European Society of Intensive Care, that basically states very clearly that echo at a certain stage of ICU admission is mandatory in the management of patients. And that's not only in the management of patients, but in the diagnosis of shock and also directing the management of those patients. Now, what are the key points? There is no RCT that demonstrates that critical care echocardiography improves patient outcome. However, critical care echocardiography is effective at establishing diagnosis of cardiorespiratory failure in the critically ill patients and in identifying factors that are associated with increased mortality. Now, based upon its utility as a diagnostic tool, it is reasonable to conclude that critical care echocardiography improves patient outcome. Now, there's another article that also looked into the hemodynamic monitoring by echocardiography, and it stated the same thing. Echocardiography is now an unavoidable tool in assessing hemodynamic instability in the ICU. So it's not anymore looking at regional wall motion abnormality. We need to understand how the heart functions with all the maneuvers and managements that we do to the patient. So what are the indications when we call for echocardiography? Very simple. The most important thing is when the patient is unstable. So not only that the patient had an MI and there's a troponin leak and there's a raised BNP, but we like you to come and help us to tell us why this patient is unstable. And that's class 1 evidence in terms of calling for echocardiography. Again, suspected aortic dissection, hemodynamic stable patient not expected to have cardiac disease, and you see that a hemodynamic stable patient not expected to have a cardiac disease. So not only the risk factor patients that we have to look at, plus the traumas and all the others. So why is it that when we call for an echo, we want something different than what the cardiologist can offer? This is what we want. We want you to tell us how full and compliant the LV compared to a normal cardiac filling. That's what we'd like you to see, is the E over E prime. The other thing we'd like you to see is to tell us about the volume of the patient. So we look at what's called VEXIS scan, which is venous excess ultrasound. What we look at is we look at the hepatic vein flow, we look at the IVC diameter, we look at the pattern of flow in the hepatic vein, pattern flow in the portal vein, we look at the pattern of flow in the renal, again, vasculature. We look at cardiac output. We want you to calculate cardiac output for us by doing the LVOT area, multiplying it by the VTI. We'd like you to tell us about the geometry, the kinetics of the RV. Not only that, we want you to tell us that there is a reduced contractility and a reduced ejection fraction, but we'd like you to tell us, is this RV tense? Is it non-compliant? Is the non-compliance of this RV is impinging into the LV? So more of a dynamic flow of how things work. So we'd like you to tell us about the acceleration time of the TR and the pulmonary vein also. We'd like you to tell us about the RVOT, VT, VTI, size of the LV, the septum position, TAPSE, MPI, myocardial performance index, and some morphological abnormalities. The same thing with the LV. We'd like you to tell us about the dynamics and how the LV is functioning. Now, this is, when we use the echo as a screening tool, we'd like you to tell us about some structural abnormality. If you could see, I wish I can play this, but it's playing. This is a patient who came to the ICU with sepsis and had just a TEE. She had sepsis and she had a fractured femur. She went to the operating room having had 2 weeks. I think Dr. Kharaza did an angio for her and put a stent in her as well. She had an MI, a non-STEMI, about 2 weeks prior after the fracture. And then she was optimized by the cardiologist in Farania Hospital. She was taken to the operating room. Nobody knows anything about her apart from she was slightly shocked with some norepinephrine. When she was taken to the operating room, I put a TEE because we couldn't float S1 in this patient. That's the only reason. We tried very hard to float S1. We couldn't float S1. So I put a TEE, and this is what I found. And this patient, and you can see that thrombus lying in the RV, waiting to migrate into the pulmonary circulation. A day later, it disappeared. And I called Dr. Kharaza in Adan Hospital to take the patient and do angio for her, and he kindly accepted the patient and was able to put a stent in this patient. So, as a screening tool, we can see so many things. We can monitor therapy with echocardiography and pulmonary artery catheter, and there are advantages and disadvantages of which one is better than the other one. Probably the combination of both in therapy will be much better. Now, the SWAN is back again. This is again from cardiology literature, where putting a SWAN in a patient with cardiogenic shock had a better in-hospital mortality compared to not putting a SWAN. The other thing that we do in the ICU that you'd like to know is we do lung ultrasound, so we see why the patient has pulmonary edema. Is it cardiogenic, non-cardiogenic? We look at so many things in the ultrasound, especially lung ultrasound, that again will tell us if the patient has pneumothorax, has a PE, has consolidation, or has any pleural disease. Now, today in Kuwait, we have ICUs that are full of cardiological tools. We have patients who are on VV or VA ECMO. We have patients on balloon pumps. We've got patients on Impella. We also have patients on combination of mechanical circulatory support. And also we have patients who have had LVAD implantants coming with other issues like sepsis. So it's very important for cardiology and critical care physician to come together and form a team looking at those patients and all the hemodynamic disturbances that we face. So we should start forming what's called the shock team. And back again, I go again to the cardiology literature. And the cardiology literature has proven very effectively, or shown very effectively, that having a shock team in a place where advanced mechanical circulatory support is employed, plus a primary PCI strategy is implemented, is going to improve the mortality and lessens the morbidity. A recent meta-analysis and a review has confirmed also that implementing eCPR, which is ECMO in CPR, have shown to reduce the mortality and the neurological deficit associated with CPR. So I see a team getting formed between cardiology and critical care physicians in trying to improve the support, the therapy, and the management of critically ill patients in the ICU, not only in the ICU, but also in the emergency department by implementing the eCPR. We see a lot of now implementation or indications for ECMO, VA ECMO, myocarditis, myocardial infarction, pulmonary embolus, trauma, postpartum acute cardiomyopathy, drug intoxication, sepsis, everything almost that we used to fear that causes a high mortality. We can put the patient in ECMO and probably treat that patient. So conclusion, critically ill patients have complex physiology. Advanced hemodynamic diagnosis and therapeutic monitoring is essential. Echocardiography is a standard tool, that's misspelled, tool in routine screening of ICU patients. Shock needs to be attended to aggressively by forming a shock team, and we need to speak the same language for a better outcome. Thank you. One thing I'd like to tell you about is next year we're going to have Kuwait is going to be the home for SWAC ELSA, which is a chapter of the ELSA organization. We're going to be having a full week of literature and very renowned speakers on ECMO and the implementation of ECMO and the indication of ECMO in the current